So your study looked at adding belzutifan to pembro after surgery for kidney cancer. What is the most important thing that patients should understand about what this combination might mean for people trying to prevent their cancer from coming back?
So Ella, this is a positive 2,000 patient randomized controlled trial of pembrolizumab plus belzutifan versus pembrolizumab in individuals with high-risk kidney cancer. We know pembrolizumab is associated with survival advantage. That's the standard of care in these high-risk patients. And the question is the addition of this HIF-2 alpha inhibitor, belzutifan, which we know also has activity, does it improve outcomes? The answer, it does. It significantly improves disease-free survival. And that improvement is durable. So when you look at the Kaplan-Meier curves, the curves go apart and they stay apart. So at the landmarks, there are significant improvements associated with the addition of the second drug. And that means it's stopping the cancer come back in the adjuvant setting, and that's important. We know before with pembrolizumab that early progression-free survival advantage translated into a later survival advantage. And we hope, and the trend looks positive, for that to happen with this new combination as well. It's associated with some tiredness and some anemia, so there are some side effects, but that's balanced against the delay in the time for the cancer to come back, and of course, relapse of kidney cancer is pretty devastating. So what do patients need to know about this? Two things. Firstly, it can prevent the time for your cancer to come back, and that may translate ultimately into a survival advantage, and that's really important. And the second issue is that needs to be weighed up against some of the side effects, but those side effects are transient. So the drugs are taken for a year, and while you're on those drugs, particularly the belzutifan, there can be some fatigue, for example, but if you stop the drug, that goes away. And we're looking for improved 5, 10, 15, 20-year survival. This is a long game.
Right.
And so that for the more mature data is really important.
So to continue off of that, obviously quality of life was a very important part of this study. Why is that especially important when we're treating patients who may currently have no evidence of disease?
So quality of life is a really complicated concept, because it's the quality of life in cancer patients who have cancer and we're treating. You know, the fight there is to try and get rid of the cancer. That's not always possible. And under those circumstances, patients are quite happy to take quite a significant dent in their quality of life to try and extend life and make sure the cancer doesn't grow and progress. In the adjuvant setting, where many of the patients have been cured with surgery alone, any intervention needs to be thought about carefully. And then, and measurement of toxicity, well, what does a 25% grade 3 anemia, fatigue, what does that actually mean for a patient? And that's where quality of life comes important. So if there's a 20% or a 30% drop in your quality of life during that period of time, that's what that fatigue means. And what we saw in this trial is we didn't see a big, significant change in quality of life with the addition of the belzutifan on top of the pembrolizumab. And while there was, during the treatment phase, a small reduction, that wasn't clinically meaningful. And then when you stop the drug, it goes away. And of course, as I said before, we're looking for long-term survival and long-term quality of life. Super important here, because we're hoping patients are going to live for a long period of time. So when you summarize the quality of life data, it kind of mirrors what we're seeing from the toxicity perspective, in that you can see a small drop, not long-term, and not clinically significant using standard methods. Now, there are some shortcomings, of course, and those shortcomings, our quality of life assessment is not perfect. The tools we're using are not perfect. And number two is we're not following up the patients. Some patients who get into problems, we don't follow those patients. So we need to think more carefully, in my opinion, about how we measure quality of life. But I'm pretty reassured that overall this package shows good efficacy, significant improvement in disease-free survival. Yes, a toxicity signal that's predictable, not life-changing, and not having a massive impact on quality of life.
Great. So thinking about the future of kidney cancer research, what is giving you the most hope?
I'm full of hope, but I'm a hopeful person. Honestly, I think going into these adjuvant spaces with belzutifan and making a difference here is a really big deal, because there are lots and lots and lots of these patients.
Right.
And reducing, this is probably the pace where we're going to cure most patients in the end.
Yeah.
It's still the case after the operation, about half the patients relapse, and those patients are in harm's way. So
Right.
this is a really important place to make a big difference.
Yeah.
Where will we go in the future? Well, of course, we need to select those patients more carefully. So we need to work out who they are. So we need to look at biomarkers to predict those patients, maybe circulating tumor DNA, maybe other biomarkers. We've had sessions at the meeting today looking at what they might be, such as KIM. But the other way I look at this is the new drugs. And there are some VEGF PD-1 bispecifics that we're developing, and there are also some cellular therapies. They're both much later, out where Pluto kind of sits in the solar system.
Right.
And we haven't brought them into around the Earth yet, but we're bringing them down, I think, and I think we're going to get these drugs, cellular therapies and VEGF PD-1 bispecifics into earlier, bigger trials relatively soon. So those are the two areas which I'm excited about.